Hello, everyone. Thank you for joining us today and welcome back from our keynote speakers and over the noon hour. Glad to have you here for the second half of our healthcare track for the Iowa Ideas Conference. I am Michaela Ram. I am the healthcare reporter for the Gazette, and I will also be the moderator for this panel, Keeping Rural Healthcare Centers Financially Viable. Before we get started into that discussion, just a couple of housekeeping items. Again, just a reminder, all of these sessions, this one included, will be recorded. So we will have those available online for you to tune back in later to take a look at. We're also encouraging all of our attendees to use the Whova app throughout our panels. And if you have questions throughout this panel, please submit them through that app. And I will see about incorporating them throughout the conversation today. But at the very least, we'll leave at least 10 minutes at the end to ask our panelists these questions. We'd also like to thank our sponsor for the healthcare track for the Iowa Ideas Conference this year, and that is the University of Iowa Healthcare. And I believe Pam has a quick sponsored ad for us to see. Okay, well, I think we'll just move along. Sorry about that for the technical difficulties, but we will go ahead and get started into our conversation. Like I said before, we are talking about keeping rural health centers financially viable. You know, a lot of financial pressures have been faced by these centers for historically, many hospitals, many healthcare centers have faced these pressures, and the temporary fix that they've received through the COVID-19 stimulus fund has provided some relief, but is that a permanent solution? What are the long-term realistic financial pathways for Iowa hospitals? What short-term and long-term improvements can be made in rural health access? So we will be talking about all of that today with our three panelists who have joined us today. First with us is Aaron Todd. He is the Chief Executive Officer of Iowa Primary Care Association, which is a nonprofit membership association comprised of 13 community health centers and one migrant health program which is a program statewide. Also with us is Mark Holmes. He is the director of the Cecil G. Shep Center for Health Services Research at the University of North Carolina. And also with us is Steve Simonin. He is the president and chief executive officer of Iowa Specialty Hospital located in Clarion. Thank you three for being with us today.
Thank you.
Great. Well, let's just launch right into it. I was hoping to set the scene. Historically, as I said before, rural health facilities have faced major financial challenges. Mark, as we've entered into this COVID-19 pandemic, do you have a sense of where things stand now as far as the financial stability of these facilities? Have things changed a year and a half into the pandemic?
So we've been tracking rural hospital closures across the country from about 2005 onward. And in the first 3 months of 2019, we were on a breakneck pace to shatter the annual number of closures. It was unbelievable how many closures we had seen in those first 3 months. COVID hit, and many people, including myself, said, "Oh, it's just going to get worse." But the supports, and as you mentioned, Michaela, the supports that with the government stepping in to help backstop a lot of that, really stopped many of the closures. There were a couple in May, and I think we've had one this year so far. But there's two things I take away from that. One is that without that government support, we would have seen a lot more closures. Two, as that stops, are we going to return back to the pace that we were looking at in the first part of 2019? I think the answer to that is almost certainly yes. So, the circumstances, the environment of where we were from 2018, 2019, as the pandemic began, were not a good place for rural healthcare providers and hospitals in particular. Your question ultimately was, okay, so what has the pandemic meant? And, how have things manifested from that? So we take a national view, and our data sets that we use to analyze hospital finances usually aren't available for 12 to 18 months until after the closure of the fiscal year. So we're just starting to see some early numbers at this point. What we're seeing so far is that, rural hospitals, I think as many people expected, generally did suffer, and in some cases considerably, when you look at the most recent year prior to the year before, particularly looking at inpatient revenue, but even more so on the outpatient side, emergency use, clinic side. There will be some exceptions for that, and a lot remains to see about regional differences. What's happened in the South versus the Midwest, and the role of that the support and what that helped to keep sustain those hospitals through that period.
Wow, that is incredibly interesting that a situation like this would sort of change the game. It's interesting. I don't know if you can kind of speak to Iowa specifically, but I know there were rural health centers statewide, including a lot of Iowa's critical access hospitals, that had ended 2020 with negative operating margins. And there were some conversations about whether there were facilities in Iowa at risk for closure. But do you see then that risk for closure has decreased then, kind of with this funding? Or I don't know if you can kind of speak to that, Mark, at all, just from a specific state perspective.
I think it probably, the last time we did a systematic assessment was in 2019, and Iowa generally looked like the Midwest, which generally is in better shape than parts of the South, for example, in terms of hospital financial distress. But to your point, Michaela, I think it's a little early, from our standpoint and the data that we have access to really get a sense of what post-pandemic finances look like in these hospitals.
Yeah, good point. We have to kind of wait and see too what happens long-term with this pandemic. But to carry on to that point, Steve, you've shared that the situation at your facility is really kind of unique. And maybe to Mark's point, things have really changed the game with these federal funds that have come through. So I hoped you could kind of share from your perspective, what do things look like at your hospital?
Both the fiscal years ending 2020 and 2021 were historically great for us. A lot of our monies came from the COVID funds, but also we did probably more procedures and surgeries in the last couple of years than ever before. And I think a lot of that is that some of the bigger hospitals were so busy that patients started coming up from the metro area. So, one of my concerns is, and Mark was pointing to this, will it last? I think some of the great things that Iowa's done is really reflect on payment parity. For telehealth, for the mental health, we do a lot of mental health visits here. That's fantastic for us. We really embraced that. But are the patients going to continue to come up? Is this a false sense of reality? So I don't know. It looks good right now, but is that going to last? So, financially and operationally, we're doing awesome here. And I think also as an independent system, we've got a couple small critical access hospitals and a bunch of clinics. We took kind of a different perspective. Instead of being extremely conservative, when the governor did open the ability to do surgery back up, we jumped in full force, and we actually ended up on target from a budget standpoint in 2020, even though we couldn't do anything for basically a month and a half. So our providers really jumped on board, and so for us, it's, I hesitate to say stuff like this, but COVID has actually been fairly good for business.
Yeah, absolutely.
Yeah.
Sorry, go ahead.
No, just from our business, it's been good.
Yeah, definitely. But that's an interesting point you raised, though. It was good for business, but you don't know how long it's going to last, right? So how do you balance sort of that long-term planning with this abnormally good year you've had?
I don't know.
Maybe that's $1 million question.
Fingers crossed, I guess. I think it's on us then to provide the best quality and service and look at this from as an opportunity to show people that in the rural areas, we can provide, the service. One of the things from I'll put my economic development hat on. We see so many people leaving the community to go to the Walmarts, to go to the Hy-Vees, to leave, our small town grocery stores or shops. This is an opportunity to say, hey, we do it here and we do it well. And, it's keeping the business and the population in their hometowns. And that's good. They're able to see us for the hero signs that we put out there and our abilities, are the same or exceed elsewhere because we're able to get the people in on time. They don't have to drive. It's maybe a nice thing for them to realize.
And Michaela, if I could just build on that, I think, Steve hits a really important point, and that is the patient satisfaction in rural hospitals is often higher. And it's everything from the ability to park and take, 30 steps to the front door rather than a parking garage and having to navigate your way, 200 yards away kind of thing. But quality of care is often better in for some of these conditions. And just, questions like there's a survey that patients get when they leave the hospital, and it asks a number of questions about how was your patient experience is the term. And one of them are like, does the nurse care about me? Were my concerns, met and heard and that sort of thing. And rural hospitals often beat urbans for many of those reasons. And so I think this experience of going to the rural hospital, getting that procedure there and saying, that was pretty, enjoyable experience. Maybe I need to rethink, why am I driving an hour and a half away for all the stuff I do? I can get it done in town and have a much better experience and, similar, if not better outcomes.
Yeah, that is very interesting. Not to kind of divert a little bit, but I wanted to be sure to include Erin to the conversation. From a primary care perspective, what has this sort of funding boost, what has this past year been like for you and your organization? How have you guys sort of balanced that additional funding with sort of the unique experience that COVID-19 was?
Sure. So our pressures are quite different, I think, than the hospital-based facilities. And so we don't have the large plants and the super large facilities, although I think some of our clinics are larger than folks might realize, particularly in the more urban centers where we're multi-story and quite large. But in the more urban or rural sites, they are a little bit smaller, as you might imagine. So COVID did deal us a blow for sure. And we did the same thing that everybody else did, really had to reevaluate what our operations looked like, pulled back. We didn't close, of course, except in a few instances. Some of our oral care services, our dental offices, and some of our school-based clinics did close for a period of time. If no one's at school, of course, we're not going to staff a clinic. And there are some special considerations for dental clinics that had us close. And so those were the areas where we also had temporary layoffs. And so the COVID funds that we did receive from Congress were used to kind of backfill some of those losses for a period of time. And we stepped up in big ways for the COVID response, particularly around testing and community testing and some other services in support of patients, and really ramped up telehealth services. We had a 750% increase in 2020 in telehealth services statewide across our network. We have kind of backtracked a little bit in that, but we have plateaued, significantly higher than we were pre-pandemic. And so we've expanded our footprint in rural in recent years, and it is an area that we get asked to expand in a lot, and to bring that integrated model of primary care, behavioral health services, and oral health services. And it's one of the places where we do tend to partner in communities where there is often the risk of or an actual downsizing of hospitals. So we lament the fact that hospitals downsize or close. That is not something we want to see happen, but it is sometimes an opportunity for us to help mitigate some of the negative impacts of that occurring. And there are some really great models in other states where community health centers or federally qualified health centers can come and bring that integrated outpatient model into a community while certain parts of a hospital are downsizing because, frankly, of the economics and demographics of what's happening in rural parts of our state. There are some places that are thriving and doing really well, right? And then there, unfortunately, are many areas that are not. The demographics or the socioeconomic trends are showing population loss and increased poverty. That's a very bad recipe for, frankly, all businesses, and healthcare essentially is a business, and those are really strong headwinds. And we can operate in all those environments either, but we can help to mitigate some of those impacts in just the different resources and assets that we bring to the table. So to answer your question specifically for the COVID funds, they were absolutely essential, and we are very appreciative to our congressional delegation for really stepping up and ensuring that the healthcare sector, including community health centers, were addressed specifically in the multiple COVID relief bills, and they continue to outreach to understand what we need, because as we all know, the pandemic is not over and is still alive and well with us today.
Right. Unfortunately, not something we're moving out of anytime soon, it doesn't appear. But to a point that you brought up, Aaron, I wanted to circle back on just sort of the need is still increasing for healthcare in these areas. And, you know, data has shown that rural Americans are more likely to be hospitalized and die as a result of COVID-19 for whatever reason. And so I wanted to ask about what lessons have been learned by healthcare facilities about improving access as, you know, this demand keeps increasing, but to, you know, the challenges that Aaron pointed out, you know, it's just harder to provide that care. Have there been lessons learned kind of for providing that care throughout this pandemic?
I think it's a continuation of understanding that we need to meet patients where they are in the way that they want to access services. So the whole concept around telehealth are to overcome a variety of barriers that people face to receive services. So whether that's transportation barriers, that's the way we typically think about that with when you're talking about rural areas, obviously, as you need to access specialty services, but sometimes it's just routine types of services, you have to travel long distances. But there are other reasons that can just be convenience, right? And we've been able to deploy other technologies in the ways that we use our patient portals and other technological advancements that I think we can really continue to propel in the marketplace. And that's really what people want. Healthcare is a service industry. Sometimes we forget about that because it's a highly specialized, highly educated. We have our opinions about the way things should work and should be. But really, we need to listen to the consumer to understand what it is that they want and the way they want to be served. And so there was a great opportunity, one of the silver linings of the pandemic, while I wish we wouldn't have had to go through the pandemic, of course, to learn these lessons. That's one of the things that we were able to kind of break some of those workflows, right? And one of the things that we need to make sure we don't do, take the time to really understand which workflows do we really want to put back together, and which ones do we want to maintain as broken or that we're going to fix in a different way so that we can get better outcomes, so that we have better access, so that we are reaching our patients in the way they really want to be served. And hopefully that has other benefits to the system in terms of better engagement with patients, better outcomes for patients, better cost to the system, all of those things that we say we're trying to accomplish as we deliver services.
Aaron, you talk about the word engagement. You know, I think that's the one thing we were able to pivot quickly after the pandemic hit towards telehealth and different things. But engagement for both the staff as well as the patients, you know, that's the thing that worries me. I mean, we've got good participation. Everybody like joins on the Zoom and things, and the patients are there. But are we truly getting as good of engagement out of, I think from the patient's perspective, the telehealth works really well. And I think that's, we don't have the stress on coming to the clinic and waiting in the waiting room and all those other things. So we're able to jump in, especially from a mental health perspective. But from the employees, that, I just fear that as we continue to move down the path of teleconferencing and Zooming and things, that we're just losing what kind of special family togetherness we had prior to this. And, going on 2 years with this, it changes the dynamic and the relationships.
Yeah, absolutely. Well, I
Okay.
see we have, go ahead, please.
I was just going to add a couple other thoughts. One is it really exposed the fragility of the workforce. And by that, I mean, in March, April of 2020, there was a mad rush to count ICU beds and ventilators, and the number of people pointed out, it's great if you have that infrastructure, but you need someone to staff it. And if you have one respiratory therapist in the hospital and they get, sick, or a family member gets sick, then you've got nothing. It doesn't matter how many capital you have. And so pivoting to that, I think it really underlined the importance of our heroes and how fragile the system is for that. I think approaching it from like a public health standpoint, the deployment, particularly vaccination, I think how the mad rush to get those numbers up as quick as possible is a great example of what some of my researcher friends in South Carolina have termed structural urbanism. And if we're going to evaluate the success of a program, the first thing we usually do is how many did you deliver? And when that's what we're basing success on, that's going to make things like mass vaccination events, deploying quickly through chain pharmacies, that's going to get our numbers up really fast. But that's disproportionately going to lead to access in urban centers. And so I think just being mindful of that, I think as we develop these strategies, the notion of, wait, what do you mean there are counties that don't have a Walgreens or a CVS? Well, how are we going to get vaccinations to them? And in really demonstrating the value of your local hospital, your local FQHC, your community health center, and the localness of what healthcare is, and as opposed to the big flagship. And then finally, the importance of trusted voices, and in particular, I'm going to speak to the faith community, which we know nationally, rural populations tend to have a stronger connection to their faith community. They're more likely to attend religious services. And I think demonstrate and embracing that and leveraging the assets of the local rural communities and what's going to work here, as opposed to what works in more urban settings, I think was a lesson learned that I hope that we continue to embed into public policy tapestry.
Yeah, absolutely. All excellent points and all things I hope to spend a little bit of time on. So we'll go back and touch on your first point, Mark, about the fragility of the workforce and just sort of how challenging it is to recruit and retain a workforce. I think that's particularly true for Iowa. I'm sure that's true for a lot of rural states. So I'm curious if there have been lessons learned, or if there are opportunities kind of as we talk about this in terms of the pandemic to better recruit and retain these healthcare workers here in rural Iowa, especially when they're high paying jobs elsewhere. You can be a traveling nurse and make twice, if not 3 times as much. I know that's kind of a big $1 million question, but Steve, I'm wondering if your hospital or your system has seen any kind of lessons learned from that.
I think it's lessons learned, and it's 3 times as much, if not more. And to see a lot of the nurses be recruited, on an hourly basis to go elsewhere, really scares us. Plus the whole vaccine mandate that we don't know the rules on yet, that's coming down, and we didn't mandate it before. But I've got a good 20+% of my staff still unvaccinated, and in the rural areas, I think it's a different perspective on mandating vaccines. So, our big thing, what's keeping us up at nights is truly how do we get those people to that place. I can't afford to lose Medicare and Medicaid. And if that's the threat, we're going to have to look at that in a different way. My thing is if once the mandate comes down, and some of my staff, the 50% of the nurses who aren't vaccinated, and 54% of my lab people, and 58% of my radiology, if they don't get vaccinated, I don't have a hospital. And so we're just, that's the struggle that we're trying to deal with right now. We haven't really lost people over the last year. But it's hard to find staff. I was talking to some people out of Kansas, and they were talking about their nurses, and they're talking about doubling wages and giving a 10,000 sign-on bonus up front, and on and on and on. And I mean, that's not sustainable. That's not sustainable in the rural areas. So are we changing the perspective of a lot of the professions out there? Are we going to be able to get back to what we were? Or is there a new reality? Is there a new paradigm? Is there a new perspective? I don't know. Truly, that keeps us up at nights here.
Mm-hmm. Yeah, Aaron, I wondered if you could kind of share your thoughts on the COVID-19 vaccine mandates, especially from a primary care standpoint. How is your organization taking a look at that?
It really varies across our network. So we have vaccination rates in our clinics that vary from the mid 40s to nearly 100%, or I think we are at 100% at one of them at this point. And it doesn't probably shock anyone that it mimics the communities in which they live, right? So the more rural the clinic, the less vaccinated, the more urban. It's an urban one that's at 100%. And so some of them have vaccine mandates already on the books, and most in the rural areas do not at this point. So we're waiting to see what the rules say specifically before really reacting at this point. But I will say, generally speaking, all of our health centers are pro-vaccination. We believe that it is key to getting out of the pandemic. And so that is our network's stance on this, of course. And we encourage all of our staff to be vaccinated. And so while we may need to, enforce a mandate, we will be pushing it more on the merits of why this is essential. What is the value proposition here? Why is that our position as an organization to begin with? And then now we do have this rule that is, kind of pushing us in this direction. It does have, kind of to Steve's point, some disparate impacts on different business lines. So, and that I think is our bigger concern at this point. When you talk about nurses and physicians and some of those other professions, they don't have a lot of other choices. So if they leave us because of the vaccine mandate, they can't go to the hospital down the street because they're going to have the same mandate. So they can choose to leave the profession, and some are. So it is a real threat, but most people need a job, and these are good paying jobs. So finding something of similar caliber is challenging and typically takes time. It's more some of those other positions where they might have choices. So for instance, for us, it's in the oral care line of business. So dentists and hygienists and others along those lines, where many dental providers are not going to be captured in the rules that are coming down, or it doesn't appear as such. And so then they actually do have the opportunity to go down the street and find a new job. And we might have a whole bunch of dental vacancies across our clinics all across the state. And we're the largest Medicaid dental provider in the state of Iowa. So we might have a whole bunch of Medicaid patients who no longer have access to oral health services in the state of Iowa. So those are the kinds of things that I think are most concerning. We've watched as other organizations have put forward their mandates, and it doesn't seem like they're seeing mass resignations. But it is a concerning thing, even if we do support vaccination in general.
Yeah, it's certainly a new dynamic in this conversation around workforce and ensuring that there's enough of a workforce to provide that access. It's interesting. I if that's okay, I kind of wanted to circle back on one of Mark's point about ensuring local access and sort of being that advocate locally for vaccine access. How does that balance with an industry that maybe some of its workforce is, taking the stance that I have my own hesitancy about the vaccine. I don't know if there's been any thought or research on this, how to best balance that? Perhaps not. That's kind of the big question, I think. Okay, so we'll just kind of move on then. Wanted to circle back on telehealth, and particularly this question about payment parity. Do we see that is now a permanent thing for telehealth? Do we believe that we've embraced it to that point, or do we think that consumers will want to go back to the in-person care that we've seen before?
I think it depends. It depends on my orthopedic. That's going in person, but for my bariatric patients to talk to their counselor, or it's fantastic. Telehealth is really a nice thing for that. Mental health, it's fantastic for mental health. We're introducing, it's like Tyto Care or whatever, the at-home little unit that you can put in your ear and your throat and stuff, and
Wow.
giving it to a lot of our patients, more of our chronic patients, and some of the families. We're introducing it to some of the businesses, so we don't have to put someone on site, that they can basically just have like a kind of a school nurse in a business and see some of our providers that way. That paradigm shifted like crazy. It's been really, really amazing for us, and there's lots of grants available for that. And, I think that's going to solve potentially a lot of our access issues, or being able to provide primary care to different businesses, or to those people who can't get into the doctor because of whatever reason. So I don't know, Aaron, are you seeing the same thing we were talking about like mental health on tele?
It's definitely here to stay. Absolutely. And I think it will definitely grow. We're even doing it in dental care. We've got some pilots for dental services through telehealth. The policy framework, sorry, my light automatically turns off in my office. There's not enough movement. So sorry, I get dark every now and then. I have to move around a little more. So the payment paradigms have not caught up. So there is still a lot of work to do in that space. So for instance, in Iowa, there is not a telehealth parity for medical services. There is for behavioral health services. So that's a deficit on commercial plans. There is a Medicaid, but there is not on commercial plans. That needs to be fixed. There is in Medicare, however, not for federally qualified health centers. That needs to be fixed. So there are still some roadblocks to some of that work. Or some of it is still under temporary authorization due to the public health emergency. So we do get that in Medicare currently for federally qualified health centers under the public health emergency. That needs to be put in permanently. And there's a variety of reasons why that hasn't happened yet, that we could spend the next 4 hours talking about all the nuances of federal health policy that we're obviously not going to do. But patients like it, right? And it is not for everyone. That's why I think, again, this is back to patient choice about what they like. But we just trained a whole bunch of people on how to access these kinds of services, and a whole bunch of them liked it. And they're not going to want to go backwards on that. I mean, that's one of our main talking points with Congress about making permanent the Medicare telehealth payment parity is if you don't do that, when we can't bill for that, we're going to give them your phone number, right? I mean, you're taking that away, not us. So it's those kinds of things, because people did find out that they are more comfortable with it than they thought. Do I still think you need a relationship with your PCP? Absolutely. And do you need to meet with them on a semi-regular basis, face-to-face? That would be my preference. Maybe some would disagree. So I think it's some combination of that. But as technology continues to progress at an exponential level in healthcare and all these other allied fields, I think you will see lots and lots of growth. As you see apps come out on your phone and ways of communicating with your care team, this kind of engagement with patients and with your care team will just continue to grow more and more. And we need to be ready for that. Absolutely.
I think what we're really starting to learn is, like, for me, telehealth is convenient. It saves me the 30 minutes of driving and sitting in a waiting room and reading an old magazine and going in and coming home and that sort of thing. And, but for many people, it can be critical. And think of the the woman who's 33 weeks pregnant, probably high to medium risk. And for her to get to see the high risk OB means showing up at the local Dollar General, catching the van that leaves at 7 a.m., takes you to the academic medical center, and then takes you home at 3 that afternoon, because that's the only transportation that she has to go that 45 minutes. That's a day off work that might be unpaid. That's who's going to take care of her kids for that whole day. Is she bringing them? It might just be easier to go, you know what, I'm feeling fine this week, I'm just going to skip it. And that's not what we want, because that leads to a poor outcome or high cost event in the future. Meanwhile, if with telehealth, able to pick up your phone, check in, do something quick for 15, 20 minutes on a lunch break, and boom, game changer in terms of access, particularly, for things like maternal deserts, which we know are really affecting rural America.
Yeah, absolutely. And I feel like early on in this conversation too, just about telehealth, in general, it was talked about mental health services were such a need in these areas too, and that telehealth could really provide a solution for that particular access point. But have we seen that? Have we seen more people utilize kind of those specialized services like mental health through telehealth, through a provider that they typically wouldn't be able to reach because they don't have the transportation, or they face other barriers to getting to those more urban centers?
Especially.
Go ahead, Steve.
No, that's what I was going to say. Go ahead, Aaron.
Yes, absolutely. I mean, we had that 750% increase in telehealth visits in 2020 compared to 2019, and I don't know the exact breakout between medical visits and behavioral health visits, but a significant component. Most of our growth year over year anyway in visits is in behavioral health and oral health, and there's just so much need. I mean, we all could just keep growing exponentially, all of the providers across the state. I mean, every time that we go into a new community, we just opened in Knoxville and in Fairfield in the last 3 months. And anytime you do that, you raise the eyebrows of other providers in the community. We work really hard to communicate with the provider community before we come into a community. In both of those instances, the hospitals invited us in. So that was an amicable growth opportunity for us. But both instances, it was behavioral health. And so we are doing bricks and mortar in that instance, but we'll offer telehealth services as well coming out of those sites. But we bring in data to demonstrate we could open 5 more clinics and still not meet the need as we come into your community tomorrow. Like, there is so much need out there for these services. So yes, we definitely have seen probably exponential growth in the utilization of telehealth as a result of the pandemic. It was growing anyway, but the pandemic really added fuel to the fire for the use of that tool specifically.
Absolutely. I wanted to make a point. We have a question here from the audience from Ashley. And she had a question about the reimbursement for the facilitation of telehealth and how can we support this? What are the pain points that need to be addressed in order to get this up and running, maybe up and running on a more permanent basis?
Can you ask, my screen froze for just a second, so I missed the first part of the question. I'm sorry, Michaela.
No, I'm sorry. So regarding reimbursement for the facilitation of telehealth, this was an audience question this was an audience member who wanted to know how we can support this. What is the pain point that needs to be addressed to get this up and running?
Well, there's kind of 2 parts that I'm not sure if that's being reflected in the comments that I made. For federally qualified health centers or community health centers, within Medicare specifically, and making that permanent for telehealth services. I mean, I think everything comes back down to cost and the federal budget, and they seem to be spending lots of money on lots of other things. So I think that they should just put us right in the budget with those other items. And we're a drop in the budget in the bucket comparatively. I also think that we will save the system money in the way that we utilize telehealth services, but ultimately there's a lot of kind of nuance in the way that different provider types are paid. But bottom line, I would say for us in that, our full delegation does support making it permanent. And Senator Ernst's office has taken the lead in trying to find the solution and working with the Senate which is obviously in control of Democrats currently, to find a solution there. And so giving a shout out to her and her staff for trying to find a solution there. So I think really it's letting the congressional delegation know that we want to make sure that all of those public programs do in fact support telehealth services and pay at a rate that makes them viable across all provider types, right? It shouldn't be that some can do it and some can't. All of them should be able to. And then here in the state of Iowa, I would say the fact that commercial plans are not required at this point is mostly the health insurance industry lobbying against it. And so it's really letting your local elected officials know that that's something that's important to you, and supporting them as they work with health insurance companies as they engage with them up at the Capitol during the legislative session to move those bills forward. There were multiple bills last session that would have made that a reality, and the only one that could get through was on mental health.
Absolutely. So yeah, we've telehealth was obviously a huge moment of growth throughout the pandemic for not just rural health facilities, but all health facilities, but obviously has been a game changer for rural health. I'm curious, have there been other innovations or other areas of growth within rural health that have helped improve access or have increased access to either more Iowans or just more Americans in general? Have we seen anything else?
One of the things that we have spearheaded the last couple of years is Project Echo. I can't tell you what that acronym stands for off the top of my head, but basically it's an upskilling opportunity for primary care physicians and other care team members where we connect with specialists who are at capacity, basically at often academic medical centers, but sometimes other hospital systems as well, and basically help PCPs and other care team members understand how to engage with and manage the care of patients with chronic conditions and other sometimes hard to manage conditions, so that they may still need to go see that specialist in an urban center or a regional center, but when they go back home to their rural area or their smaller city, they can work in partnership to understand better how to manage that so they have to travel less often. So that's one of the ways that we have, and basically it's the system of kind of some didactic training and then case studies, it kind of live via Zoom that we've been doing. And this is a proven model that came out of New Mexico and has been used all over the globe, and was first started on Hep C, I believe, to really try to move the needle in the care of persons with hepatitis C. And so we have tried to bring that here to Iowa, and other systems have used this now too. So that's one of the ways that we can help people stay in their communities, often rural communities, without having to travel to Des Moines or Iowa City on a regular basis, and rely more heavily on their PCP or care teams, who then feel more comfortable managing more complex cases in their health center in this case, but potentially other provider groups. And that's another way to kind of tackle some of the shortage of specialists too, who only have so much capacity to take on so many patients in some of those larger health systems.
Yeah, that's fascinating. Very interesting. To kind of circle back to the beginning of our conversation when we were talking about federal funding and the sort of opportunity that has been presented by the CARES dollars and things like that. I think it's kind of been agreed upon in this panel that this is really kind of a temporary fix. We don't know what the financial stability of these facilities will look like long term. So what would you like to see in terms of permanent fixes? What would be good opportunities to ensure the long-term financial stability of these facilities? I don't know, Mark, if you want to talk broadly about that, or if Steve or Aaron kind of want to talk more locally, I open it up to the panel.
I'd love to hear Steve and Aaron's take. I can give a national view, but
Mark, we're from a critical access standpoint, I'm just going to talk from a hospital perspective. We're looking nationally at the REH on the rural emergency hospital situation, and Iowa was kind of out front as far as proposing a plan for that, which it came back significantly less financially favorable for the rural hospitals. So it'll be interesting to see how many actual hospitals transition into a rural emergency hospital. Like we talked about the other day when on the pre-call, it's kind of an interesting. The rural emergency hospital would require hospitals to give up all acute care services. So I think that you've seen probably over the last 20 years, the majority of rural hospitals either build or redo their hospitals. So to go back to a community and say, okay, well, we're going to change from an inpatient hospital to just outpatient services and ER. If you're not having some real desperate times, that's going to be a hard pill to swallow. So it's there's other demonstrations in other communities of different types of hospitals. And, I've got a lot of friends in kind of the tweener hospitals, too big to be critical access, but small and have a lot of Medicare and Medicaid, and they're suffering kind of greatly without the favorable reimbursement that we get in critical access. So there's got to be some changes there as well in order to keep those hospitals surviving. So I don't know. There's lots of demonstrations out there for the rural hospitals to remain viable and alive, but I don't know.
Michaela, I think Steve hits a nice point there, in that sort of rethinking how we pay for it. I mean, that's jumping a canyon. But right now, most healthcare providers get paid to manage sickness. There's a move to value-based payment, which is trying to get paid to keep you healthy. But we still are often constrained by the way our healthcare system is designed, with this triangle of the person who's paying doesn't trust either the patient or the provider. And so you must be lying and you're trying to get money from me. So here's all these forms you need to go out, and here's a rule and a regulation, and I need to come in and inspect you every once in a while. And for rural places in particular, this can be suffocating. With guidelines such as, well, if you're going to provide this service, then you need to have this kind of healthcare professional within X miles and be available for these many minutes, which is great in theory, until what that means is, well, we can't do that, which means we can't provide that service at all. And the justification behind that is often the clinical and equality. But if you're in active labor and you need a cesarean section, and the hospital says, well, we didn't have an anesthesiologist within 60 minutes, so you got to drive an hour and a half to Iowa City or Des Moines, I'm not sure how that's helpful. So there's like these models, as Steve mentioned, there's CMS has a program called CHART that they've trying in 4 different states. Pennsylvania has a model where it's basically flipping on its head, and it goes to community and say, here's X million dollars. We don't really care how you do it, just make people as healthy as possible. And so you can say, all right, rather than have all these rules about we need to have X, people per Y, this is what we think we need here. And we're only 20 minutes from this large facility. So in this case, we're going to, have a stable and transfer kind of a strategy. But over here on the other side of the mountain, we need to have something that's going to be a little more self-sustained. And so over here, we're going to have these kinds of service profile, which is really difficult in our existing system. And I think something like that, where we basically break the mold and start, and show the ability of a model like this to work in rural is probably what's gonna take to be sustainable.
I think that's right. I often say the future of healthcare is collaborative, and I think that can work especially well in rural areas. Not that some things don't work well in a competitive environment, but when we're talking about things like population health and really trying to move entire populations to be healthier than they are today, and to reach broader goals of lower costs and better outcomes of entire populations, we need to be working together more closely than ever before. And when we think again about some of the dynamics that we talked about earlier in this session around decreasing populations and increasing poverty in many rural areas, those are really hard headwinds. And so we need to be a little bit more open, a little bit more trusting, a little bit more transparent about what's happening, and have some conversations about where we're headed and what we can do and how we can partner, and who's best positioned to do some of that work. Who has the right assets, who has the right payment methodology, who targets the right kinds of patients and serves them the best. Those are the kinds of conversations that we like to invite. We often will get a call from an elected official or from a community member saying, this hospital is struggling, this community is struggling, and in fact, they might even close in like the next month. Could you open a facility and in the next month? And our answer is, of course not. We can't open a healthcare facility in a month. However, if we would have been talking for 6 months or a year, we could have talked about what we could do, not necessarily to save the hospital, but to mitigate some of the negative impacts. And I mentioned there's some really great models in other states about ways to think about ensuring that communities maintain their emergency room and other specialty services that are really supported by the population base that exists. And then other ways that they've partnered with community health centers to kind of prop up other parts of the healthcare delivery system based on the unique assets and reimbursement methodologies and other resources that come with that model. So it really becomes a win-win, both for that hospital and for the community that needs to maintain those healthcare services in order to be a viable community, right? We all know you lose that hospital or your basic healthcare services, and your future as a viable place for businesses and persons to live goes down really quickly. So I think getting to that point of conversation about how do we organize ourselves to get the best outcomes and have those more transparent conversations about who's resourced well to do certain things in our communities, which I know is a lot harder to do than it sounds like I'm saying it is, then we can accomplish some really great things, I think.
Absolutely. That's a great point to end things on, I think, as we hit the 10-minute mark and want to take some time for audience questions. So a reminder to our attendees, please use the Whova app to submit your questions that you have for our panelists here. As I start going through them, I see we have a lot. So thank you for submitting these. The first one is from JF. They asked, what challenges do you experience in LGBTQA+ healthcare access and inclusivity? And also from a veteran standpoint, how does rural healthcare supplement the VA healthcare system, and how could they offer an alternative to the traditional system? So kind of two parts to that question to whoever wants to take that.
I can talk a little about the VA question, and that is the VA has been, I guess I'd use the word aggressive in recognizing that the system is not everywhere, and designing programs and policies to leverage the existing healthcare system and not requiring those eligible for VA benefits to use the VHA system. More work to be done, absolutely. Are they familiar with, and is every healthcare provider as up to speed and facile with VHA or VA policies and the unique aspects of being veteran, whether it's PTSD or TBI and other common syndromes among the veteran population. There's more work to be done there. But that has been a priority the last few years in particular to try, and largely resulting out of some troubles that the system had about a decade ago to try, but deliberate efforts to try and increase access, particularly to rural veterans who may not be as close to the VA system.
Absolutely. I don't know if Steve and Aaron could speak to that LGBTQA+ question, and as well as inclusivity and access for those Iowans.
Sure. We have a pretty proud history at community health centers of serving LGBTQ+ Iowans. There's always more that we can do. We have a lot of specialized services that are targeted toward that community, particularly in Des Moines and Waterloo, but all across our network. We have the project here in Des Moines that has some of the best HIV suppression rates in the country. And so we have, and then there's of course, a whole multitude of other services above and beyond those as well. And so it's been interesting to see some proliferation of additional services targeted at that community, often touted as like the first time there's been a clinic focused on the healthcare needs of LGBTQ Iowans, when we're like, well, we don't have your marketing budget, but we've been doing this for 25 years here in Des Moines. So, but I'm at the same time, I'm really happy to see other providers finally catching up and taking on those services because they are essential and needed. So, I still think there are significant barriers which tend to be cultural on the part, frankly, of staff and providers. And that's, I think, where we have really spent our time, is helping staff and providers understand what LGBTQ plus patients need. What does a welcoming and inclusive environment look like and feel like to them? And then ensuring that they do have access to the services that they seek, whether that's in the communities in which they live, or if we can't offer that there, then we do, of course, have a network of community health centers all across the state, and we are committed to helping them overcome those barriers to access, whatever that might look like. So we are not perfect by any means, so I don't want to leave with the impression that I believe that's the case, but I feel proud of what we have accomplished in that space, and we're committed to doing more. We have also had a couple of partnerships with the VA, specifically the rural VA office out of Iowa City. One of our biggest challenges is identifying veterans. That sounds like a really simple problem, but it's not. It's really about how you ask the question and people's feelings about being in the armed services. It's significantly more complex than you might realize, and then capturing that data upon intake. And so we have done some pilots in the Burlington area in particular, in partnership with the VA, and then we've had some partnerships as well down there to do some coordinated care management systems that we've also written some papers on and presented across the country about ways that community health centers and the VA can do better partnerships. I think the VA is interested, and yet their system is extremely challenging to work with, as you can imagine. And so they have resourced these pilots, but even moving them beyond one partnership with one discrete site is very challenging. And there aren't federal resources always to kind of support it, kind of expanding beyond that, beyond like a grant funded initiative. So I'm hopeful that we can continue to do more there, but it's hard to move it out of the pilot phase. Even when you can demonstrate really good success, it's really challenging to expand out of that one pilot.
Absolutely. We have another question here from Ashley. She asked, at the onset of the vaccine rollout, the deep freezers needed to support Pfizer were in short supply. Has this been remedied, or is this still needed to support rural health? And maybe I could tack on to that question too. Is there anything else that's needed to support vaccine rollout in these rural areas?
I can just note that that issue has not been raised to me. So my understanding is that we continue to have sufficient vaccine supply to everyone who wants it. So continue to send anyone and everyone to our health centers, and we will get them a vaccine in their arm as quickly as we possibly can. So
Yeah.
I'm not aware that we have any kind of logistical or operational issues within our network to ensure the availability of vaccines.
Yeah,
That's a good point. It seems that the discussion around vaccine rollout has really changed from logistics and resources to more of that addressing hesitancy, addressing misinformation. Would you find that to be true, Steve?
Say that again.
Would you find that to be true, that that's how the vaccine rollout has changed?
Absolutely. We have plenty of vaccine. It's just the hesitancy right now.
Absolutely. Maybe that's a good question to ask. Anything else that's needed to help you as healthcare facilities support this vaccine rollout and to increase the vaccination rate?
No, I just like to see, they say the guidelines will be here by the end of the month, hopefully, and then we'll see what happens from there. So it'll be an interesting couple of months. I think I was on an AHA call the other day, and they were talking about some of the states, Maine and California, who had the mandates, I think in October 1st or whatever deadline. And like Mark, you were saying that there's a lot of people who get their vaccine at the 11th hour. And so, we're hoping and praying that that's the same situation here.
Absolutely. Okay, well, I think we just have a couple minutes left, so that's probably all the questions we have time today. So I wanted to thank our panelists for joining us today. Thank you for sharing your perspective and talking about all of this. I know this was a big topic, but I feel like we walked away with a lot of good points here. So thank you all, and thank you to our audience members for attending and listening and participating with your own questions. We appreciate you joining us. Feel free to use the Who've app to continue the conversation. Otherwise, we will see you in the next panel starting in a couple of minutes, which is a part of the diversity, equity, and inclusion track, and it's on vaccine acceptance, actually. So we'll be able to continue this conversation there. But thank you all again.
Thanks, everyone. Have a good day.
Thank you.
Take care.